Nobody here yet. Hi, everyone, and thank you for joining us today. I'm Kevin Heaney, Vice Chair of the Fertility Friends Foundation Board and a father of two through surrogacy. For those of you that may not know us, we are a Canadian registered charity that offers grants to cover expenses associated with fertility treatment such as IVF, egg and sperm donation, and gestational surrogacy. To sum it up, we believe that no one should give up their dreams of becoming parents because of financial resources. We're pleased to be hosting this important conversation as part of our ongoing Your Fertility Guide webinar series, which is designed to support, inform, and empower individuals and couples navigating fertility challenges. Today's topic is especially meaningful as we focus on 2SLGBTQ+ pathways to parenthood in celebration of Pride Month. I'm honored to introduce our guest speaker, Dr. Khalil Ali, a respected expert in reproductive medicine who brings not only clinical insight, but also deep compassion for his patients. If you have any questions during the presentation, please feel free to use the Q&A box, which I will be monitoring throughout the session. A quick reminder, this webinar is being recorded and will be shared with all registrants afterwards. Without further ado, please join me in welcoming Dr. Khalil Ali. Hey, Khalil.
Hey, Kevin. Thank you for the wonderful words. Bear with me 1 second as I put the presentation onto the screen. You should be seeing on your screen now Pathway to Parenthood for the 2SLGBTQ+ community members. Today, I'm going to really talk about all the different modalities and assessments and treatments that we can assist families on building and growing their family, and things that are offered at Tripod Fertility where I work. One of the first services that we offer at Tripod Fertility is fertility assessment for individuals, family planning through the third-party program. And the third-party program really talks about anybody who, intended parents who require the assistance of sperm donor, egg donor, or a surrogate to grow their family, and in the guidance of the Health Canada regulations. And I'll get a little bit about what the Health Canada regulations are and how they affect the development of your family building. We'll talk about in the family planning, we have the fertility preservation, so egg freezing and sperm freezing or embryo creation. We also have fertility treatments like IUI, stimulated IVF, natural IVF cycles, egg thaw, and oocyte creation. And then also there's the option of gestational surrogacy. Some things that I also want to talk about in the process is the genetic testing. Many people in the process always confuse a couple of them with genetic carrier screening and the PGTA, PGTM, and PGTSR. And I'll dive into those and explain a little bit about what each one of those are, where they're done in their process, and what the benefits of those specific genetic testings are for.
Great. When I went through surrogacy 10 years ago, those options weren't even available. So it'll be interesting to find out more about that.
Perfect. With the fertility assessments, I divided into two groups of individuals, assigned females at birth individuals, and we talk about the things that we do for the fertility assessment. Those will be infectious disease screening, hormone screening, pelvic ultrasound for looking at the antral follicular count or how many follicles we see in the ovaries, right or left, and then a sonohystogram looking at the uterus to see if there are any structural abnormalities. These are some of the fertility assessments or basic workups that would be done for an individual who is assigned female at birth. For individuals who are assigned male at birth, we have some tests that can be done as well: infectious disease screening, hormone screening, and semen analysis. With the semen analysis, we look at the World Health Organization's guidelines that look at the concentration of the sperm, the motility of the sperm, the way it swims, the morphology, the way it's shaped, and the volume of the sperm. All of these things would inevitably play a role on on fertility and impact how the sperm can then fertilize eggs. And so we start with that fertility assessment. With fertility preservation, we have essentially two categories, and I break it off to the assigned females at birth individuals. There are two options. Either we go through egg freezing, And that's a process that involves stimulating the ovaries to produce multiple eggs. And once they are then retrieved, and they're frozen for future use. So that's one option. That could be before you start transitioning. That could be at any point in time that you decide that you're not ready to build your family just as yet, but you want to store your eggs for later use. And then for females who are assigned, for individuals who are assigned female at birth, we also have embryo creation. Okay, and that could be a process that involves a process of stimulating the ovaries, produce multiple eggs. We retrieve those. We use sperm either from a partner, either from a donor, and then we would fertilize those eggs, and then those embryos would now be frozen for future use. At that point in time, you could decide to do a transfer into yourself or into a surrogate, and then store the rest of it for later for addition into the family. Or you can just freeze all of them now and decide at a later date when you decide you want to grow your family.
I'm curious, what demographic are you seeing taking advantage of this? Are individuals coming in younger than previously, or has it always kind of been the same demographic?
So that's a good question. And so with the egg freezing, we do see a little bit of a younger population. They're the individuals who have decided they're not ready to grow. So there's two groups into it, but in the third party specific, it's the individuals who are going to be going through transitioning, and before they start taking hormone therapy, they want to freeze their eggs before they go into that process. That's a big category of individuals who are going through that egg freezing. And then with the embryo creation, it's a little bit later, like middle-aged individuals who have, now decided that they want to grow their family, or build their family, and then they go through the embryo creation process.
Great.
The second group of individuals, or second group of fertility preservation, is for the assigned male at birth. And for them, essentially, there is two options, but the main one is sperm banking. That's where sperm is collected and frozen for later use. The way that the medical field dictates it right now is that it's best to do sperm freezing prior to starting any hormone therapy. Okay. If you decide that you want to go into hormone therapy, you still can, and you can do freezing afterwards. It's just that there's studies that show that it is a little bit less it is a little bit less effective sperm if after on therapy. The second option for individuals who are assigned male at birth is to use their sperm, use donor eggs or partner eggs to create embryos and then freeze embryos again. So similar process for them. Now, what do we do with that sperm, with that egg, or when you're ready to proceed on? There's a procedure called the intrauterine insemination, or an IUI. It's a process whereby specially prepared sperm, so the sperm that's in the ejaculate is actually washed and prepared, and then is placed directly into the uterus to increase the chances of pregnancy. Okay, this may be single individuals who decide that they don't want a partner, or that they haven't found a partner but they want to grow their family. This is an option for you. The second option is in vitro insemination, or IVF. It is a procedure whereby an egg is fertilized by sperm outside of the body. And as we go through the process, essentially, you first have a consult with the doctor. You do your fertility workup, some baseline blood work and ultrasound. You would do your ovarian stimulation for the follicles to grow within the ovaries, and suppression of your ovulation so that they continue to grow. Once the oocytes mature within the ovaries, we would then trigger for an egg retrieval. And then once the eggs are retrieved, either frozen for cryopreservation, or they're fertilized. In the case of IVF, they're fertilized with sperm. And then once those are frozen, we can do some additional testing, which is the PGTA, PGTM, or PGTSR, which I'll get to in a couple of slides. And then after those are completed, we can do the embryo transfer. We would do 2 weeks, the wait period, the dreaded wait period for everybody, where we're trying to wait to find if the embryo implanted, and then the pregnancy test afterwards to either celebrate the pregnancy, or we sit down together with you as patients and then discuss what are the next steps for another transfer. The second part of or the is the oocyte thaw and embryo creation, and this is another way or modality of which growing your family can take place. Cryopreservation of the eggs, like I mentioned, can take place. You're not ready to proceed to grow your family. You don't have a sperm that you're ready to use, so you freeze those eggs. At the later date, when you do decide that you're ready to proceed and you have a sperm that's available, it's the process where previously frozen eggs are thawed under very specific conditions, and then they're fertilized with the sperm outside of the body and cultured to embryos. And once they're made into embryos, at that point in time, they can be transferred into either you as a patient or a surrogate if that is necessary. Talking about third-party reproduction, it goes hand in hand with some legislation that govern us in Canada, and there's two major ones that really talk about how we can maneuver this space. The first one is the Assisted Human Reproduction Act. It's federal legislation in Canada, and it's the laws that regulate assisted human reproduction, including IVF and other procedures like IUI and oocyte thaw and embryo creation. It aims to protect the health, safety, dignity, and rights of individuals involved in assisted human reproduction. It addresses the ethical concerns surrounding creating embryos and using them for research, and the use of donors and altruism. In Canada, the regulations dictate that a donor or a surrogate must go through altruistic approaches, and they're not allowed to be paid, but they're allowed to be reimbursed, and the legal contracts will outline exactly what those reimbursements can entail, and it prohibits the human cloning, and non-human transplants. So taking a human embryo and putting it into an animal in research, or an animal embryo and putting it into humans for research.
One interesting point about legislation in Canada too, from my understanding, and you might confirm this, in Canada, you cannot select the type of embryo you want to implant. Is that correct?
That's most definitely correct. So that's also part of the legislation in the Assisted Human Reproduction Act. It prohibits the gender selection of embryos, except under very specific conditions. Okay, and those specific conditions are there would be a risk for the child if you were to select against male or female. And the examples of that are very specific genetic conditions, which most of the times are X-linked conditions, X-linked recessive, and that's what we do in the genetic carrier screening. An example of it is SMA, or spinal muscular atrophy. It's an X-linked recessive condition, which means that if the male child were to carry that the condition on the X gene, it would be affected, and then the child dies very shortly into life, not a very long life. And therefore, in situations like that, the legislations allow you to select against male children because of the implications of that child being born.
Perfect.
The second legislation that governs us in Canada is the Health Canada Safety of Sperm and Ovum Regulation. This came into effect in February of 2020, and it is constantly evolving. It's a Canadian laws under the Assisted Human Reproduction Act, that aims to minimize health risks associated with using donor sperm or ova, which is eggs, in assisted human reproductions. They apply to establishments and health professionals involved in processing, importing, distributing, or using donor sperm or egg. And it focuses on reducing the risk of infectious disease and genetic disease transmissions. Okay. For the understanding of intended parents who would be going through their journey, we have to look at the regulations talk about donor sperm and donor egg, but it's a little bit in the way that they talk about it is they talk about the sperm or egg that is going into whose uterus. If the uterus is not the sexual partner of the sperm or egg provider, that the sperm or egg provider, although may be the intended parents, they're considered donors and have to be screened in a certain way so that the risk can be assessed, and discussed with that person who would be carrying the pregnancy. And so for an intended parent, what we have to look at is the things that would affect you. And the regulation is very long, but the things that would affect you is that you need to ensure that four things are done when you are doing your donation for creating your embryos. It would be infectious disease screening within 30 days of the donation for an egg source and 7 days for the sperm source, a physical assessment that would be done at the clinic, medical assessment, which would be done with the clinic, and it's a questionnaire that is outlined by Health Canada, and then genetic carrier screening or in a genetic assessment. The genetic carrier screening is good for life. The genetic assessment has to be done within a certain time frame. The genetic assessment is generally a 3-generation pedigree plus a questionnaire that asks you if certain family members have, and it goes through a bunch of symptoms to ask if you have certain conditions. The genetic carrier screening is a little bit more comprehensive, and it is a test that identifies if an individual, if you carry a gene with a change or variant that can impact your child. Most carriers are healthy with no family history, but they are at risk on passing on a genetic condition to their child. And genetic carrier screenings test look for autosomal recessive or X-linked recessive conditions, and that's the mode of inheritance of how it gets passed on from parent to child, right? With the autosomal recessive and X-linked conditions, they have different chances. With autosomal recessive, if the sperm and the egg provider are both a carrier for the same condition, there would be a 50% chance that the child will be affected by that disease process or that genetic condition. And with X-linked conditions, like I mentioned, all the male children will be affected by that disease if the X is passed on from the affected egg. There's a 50% chance for the female children that were born to be affected by that condition. And the reason for that is with a male child, there is the XY. The X comes from the egg, the Y comes from the sperm. And with a female child, it's XX, and the X comes from the sperm, and the X comes from the egg as well. The other tests that kind of get confusing for a lot of individuals is they talk about test or pre-implantation genetic testing. So they talk about genetic testing, and individuals say, okay, there are two testing that come about. Genetic carrier screening, that's done when you're creating the embryos or before you create the embryos. And then the PGTA, like you mentioned, Kevin, that wasn't around when you were going through the process, are the testing that can be done after the embryos are created, but before you go into transfer. Okay. The first one that is recommended to most individuals is the pre-implantation testing analysis. It is a genetic study of embryos produced during an IVF treatment to identify numerical chromosome aneuploidies or imbalances. And the test identifies chromosomally normal embryos and can help improve your chances for a healthy ongoing pregnancy. So on the left on this karyotype, you see chromosomes 1, 2, 3, 4, all the way to 22, and it would either be XX for a female child or XY for a male child. This is what a normal embryo looks like. The PGTA analysis does this analysis and looks at, again, all the chromosomes. And as an example, you see in chromosome 21, there are 3 copies of that chromosome. There's only supposed to be 2, which would be normal. This extra copy would result in a child that would have Down syndrome and would be considered an aneuploidy and would not be recommended for transfer by the clinic. On the other side over here, you have the XY chromosome, that the Y chromosome is missing in this individual, and therefore again would be an aneuploidy, resulting in the clinic saying we would not recommend to transfer that embryo.
Do you find that most patients proceed with this testing now?
So it really is something that is a debate between physicians on whether it is important or not important. At Tripod, we generally recommend it to our patients to do PGTA testing. And some of the reasons why people say it's not that necessary is because there are certain age brackets in which euploidy rates are higher or lower. So the normal chromosomal balances are higher or lower. And so based off those numbers, sometimes clinics will say that if the egg source is younger than 30 years old, they may not necessarily recommend it. But again, it gives very pertinent information onto the transfer. If there's a miscarriage, was a miscarriage due to implantation failure, or was the miscarriage due to genetic abnormalities within the embryo itself?
Okay. And you may not know this, but do you have an idea of cost for the testing?
That's a good question. And so at Tripod Fertility, there would be a biopsy fee to essentially take a couple of cells from the embryo, which is a base fee, and then there would be PGTA testing, which is $515 per embryo. Right. So if, for example, you had a cycle where you had 10 embryos, it would be 515 multiplied by 10 plus $2,500, and that would be able to test all 10 of your embryos to see if they were euploids or PGTA, to do the PGTA analysis.
Okay.
The second potential pre-implantation genetic testing is PGTM analysis, and this one is a little bit different. This PGTM can determine if the embryos are affected or unaffected with a specific single gene disease. The test is custom designed for the specific gene mutation, and it analyzes DNA from each embryo. Unaffected embryos can be identified and preferentially selected to be transferred during future embryo transfers. So remember, I was saying that if the egg source was a carrier of a condition and the sperm source also carrier of a condition, then you may not want to transfer that embryo because of the potential risks or implications with that. With this PGTM analysis, it can be determined. So the egg provider and the sperm provider with the big A, with the big R, little r is what's denoted as a carrier of a condition. So both the sperm and egg provider are a carrier of the sperm condition, of the genetic condition. The little r represents the affected gene, okay, and the autosomal recessive condition. And there's 25% chance that the two little r's come together to make that baby. That means 25% of the time that child will be affected by the disease process, and it will actually show in whatever those symptoms may be. 50% of the time, either the big R will come from the egg and the little r from the sperm, or the big R from the sperm and the little r from the egg, and will give you 50% carrier status. That means that that child would be just like the sperm or egg provider, live a normal life, not really know anything unless they did genetic carrier screening, and it really only affects them if they decide that they want to grow their family later on. At least they have an understanding of some genetic conditions that they may then turn to their partner and say, let us do some testing before we grow our family. And then 25% of the time, the big R's from both the sperm and egg can come together, and then we have a completely unaffected child, and that gene or that genetic condition kind of gets eliminated from that part of the genealogy or the family passing on. This test, like I mentioned, is they do for specific genes only or specific conditions only. So first you need to identify which one that you're a carrier for, both the sperm and the egg provider, and then we can create probes and do the testing for it. And then the last one that's offered is a PGT-SR. It screens embryos for chromosomal imbalances or extra or missing chromosomal material resulting from a parental structural rearrangement, and it also detects numerical chromosomal abnormalities. So it also does PGTA. Okay. And what exactly is it looking for? Are balance. So there's three things that they essentially look for in the PGT-SR is balanced reciprocals. As you can see, these are the two chromosomes. They didn't come out the way they were supposed to. The blue section actually ended up on the pink chromosome, and the pink section ended up on the blue chromosome. That's a balanced reciprocal. They look exactly normal, but there is that change, and that would result in some type of genetic abnormalities. Another one is inverted chromosomes, where the order was supposed to be 1, 2, 3, 4, 5, 6, but in the process when the chromosomes were pulling apart, it ended up being 1, 2, 3, 5, 4, 6, which can result in, again, once the chromosomes are being translated and decoded, they can have some changes into the processes. And then the last one that it looks at are Robertsonian translocations, where it's not really visible for you to see, but there is the long arm on the pink, the short arm on the pink, and then this long arm on the blue. The long arm of the blue ended up going on top of the short arm of the pink, which would affect the processes in the decoding and the development in different fetuses, as well as genetic conditions. This is very rare that we do PGTSR, but there are some situations. And again, most of the times these are presented in advance. Somebody already knows they have a Robertsonian translocation, and then that's when we go to opt into doing the PGTSR. Then after we create embryos, we've done PGT testing or pre-implantation testing, we now may need to go into surrogacy or gestational surrogacy. It's the process whereby a person carries an embryo for an intended parent um, or parents, and the gestational surrogate may or may not be involved in the creation of the embryo. So there are two options. Where they're not involved is you're using a donor egg or partner egg, a donor sperm or partner sperm, and then that surrogate is a third individual into the process. Occasionally, there's something called traditional surrogacy, where the egg provider and the person carrying the pregnancy are the same people, but they're not part of the partnership that is growing the family. Okay. Um, as per the Assisted Human Reproduction Act, it is illegal to pay the gestational surrogate, as they must participate altruistically and can only reimburse, and that's completed, or that's done through the legal and agreements that would need to be done. And then treatments involving a gestational surrogate require reproductive and legal counseling for all parties. Then the last thing that we always talk about, or the question that always comes up, is what happens with embryos after we're done, or sperm or egg when I'm done building my family, right? So there really is four things that you can think about. The first one is you decide later. You frozen, you preserve your sperm, your egg, or your embryo, and you're not ready to use them yet, so you continue to store them for as long as you decide that you want to. The second option is donate them and give them to somebody else that may require sperm, egg, or embryos to go on to their journey and build their family. The third option is donate to research, and that helps to improve assisted human reproductive technologies. And again, the Assisted Human Reproduction Act kind of outlines what can be done in research for those sperm, eggs, or embryos. And then the last is discard them. They're thawed without retaining any viability and discarded as medical waste. And again, that's an option that, for whatever reason, an individual decides that they don't want to donate them, or they don't want to keep storing them because they're finished building their family, or they don't want to use them, give them to somebody else, and then they can discard them.
What would happen under, let's say, circumstances where maybe somebody's moved away or even passed away, and these embryos are here? Is there any process for what the clinic does after a certain period of time with these embryos?
So yes, because embryos, sperm, and eggs, they're all very important genetic material, and they all were created with a pretty decent investment for intended parents. Um, uh, we go through a process, right? We store them. There's the annual storage fees that take place. We reach out to the intended parents when the annual storage comes up, and then we continue to go about storing it for as long as they do. If they don't reach out, if they don't get back to us, we have a process in place where we have to reach out to them by phone, by mail, and we really try and get to them before doing anything with those embryos, sperm or egg. And in that sense, if there's a death that takes place in the consents when you're creating your embryos or storing your sperm or your egg, you sign the consents of what it is that you would like to do. Okay. So if you say, so again, these options are presented to you. Are you going to donate them to a family member or somebody else? Then that person then takes ownership or responsibility of that sperm, egg, or embryos. Are you going to donate them to research, or are you going to discard them because you don't want them to be used? So we really try and reach out to intended parents if there's some reason that we haven't been able to. We try multiple avenues because sometimes somebody changes an email address, something gets hacked, a phone number removed. We don't want that to be the reason that your embryos are then discarded. So we don't discard it until we try and actually get a hold of you. And then essentially that brings me to the end of my presentation. Some contact information for how you can reach out to me and Tripod Fertility. Our email address, thirdparty@tripodfertility.com. Our website at www.tripodfertility.com, and our phone number 905-201-3420. These contact information can be provided to anybody. And at this point in time, I'll open it up, Kevin, to whatever questions that you may have for me, the chat may have for me, and we can go from there.
Perfect. I'm just checking the chat. There haven't been any additional questions. Um, do you see any new trends coming up for this community and things for people to think about?
There are a couple of trends that go back and forth, and though the big one is same-sex male couples who want to use donor eggs to grow their family. Okay. There's always the age-old debate of whether using fresh eggs through a fresh egg donor or frozen eggs from an egg bank. And there's a shift that goes back and forth, and each one of those have their pros and their cons. The frozen eggs from an egg bank are great because they're readily available. You purchase from the egg bank. You go on. You look at some criteria that intended parents are interested in. You purchase what eggs that you would like. We make sure that they're done and frozen in accordance to the Health Canada regulations. They get to the clinic, and then they are created into embryos. Okay. Um, with the fresh egg donor, there's a little bit of a longer period in time that goes on over there, whereby we have to first do their initial testing, investigations, do the Health Canada requirements of their sperm freeze. Sorry, not the sperm freeze. We need to do um, uh, um, their AFC for the antral follicular count, their blood work, their hormones, their infectious diseases. Then we do genetic carrier screening. All of those things are completed. And once they are a good candidate, the legal and counseling needs to take place. After that's done, then we move into the egg retrieval procedure. So that process is generally using a fresh egg donor, takes 3 to 5 months. Whereas if you're using a frozen egg donor from an egg bank, will generally take 2 to 3 months, right? When we talk about pricing, they're generally roughly about the same when you compare them equal to one another. If you were to do, so Egg Banks sells eggs in lots of 6 or 8, and they're generally, depending on what egg bank you go to, somewhere between $8,000 to $12,000 to purchase a lot of 6 or 8 eggs. And an egg donor, a good egg donor, will retrieve anywhere in the ballpark of 15, 20, 30, 40 eggs in a cycle, and all of those become yours as the intended parent. And so when you compare that, if you were to purchase 10 eggs 4 times to get the same 40, that's almost $48,000 that you're purchasing eggs. And an egg retrieval with an IVF and an egg donor is a little bit less than that, but around the same ballpark of what you would have to pay to create embryos using a fresh egg donor.
Great.
So that's kind of a trend that we look at. Another trend that we see going is a lot of IUI procedures that are taking place using donor sperm from a sperm bank before individuals try to go into an IVF cycle. And I think that one generally goes to the result of the fact that it's a younger population who are doing the IUIs, but an IVF is a little bit more of a financial investment. And so sometimes people say, let's try the IUI first. We have good fertility assessment. We'll try and see if we get pregnant. And if not, then move on to an IVF cycle. is what we see a lot happening as well.
Perfect. In terms of sperm washing, is there anything that could complicate things or somebody may have to think about ahead of time that that you could talk about?
Perfect. So when we talk about the Health Canada regulations, a big portion of individuals are international same-sex male couples that come over to Canada for the laws in Canada that are different in Europe, that are different in Australia, that are different in other parts of the world, as well as the pricing is cheaper in Canada than it is in the United States with the dollar exchange and things like that. So a lot of people come here to produce their and grow their family in Canada. The same sex male couples, because the person who would be carrying the pregnancy is not their sexual partner, they're deemed as sperm donors and they have to freeze their sperm. Okay. A lot of times, what ends up happening for some of these individuals is they do a semen analysis wherever they are locally. Everything is good or within the parameters of being okay, and then they travel to Toronto to produce their sperm, or they travel anywhere to produce their sperm. They're not in their element. It's not the same country. It's a different time zone. Sometimes, it's an 8 to 10 hour flight. Dehydration from being on a plane, and all these other factors come into play, and you come in to now produce your sperm sample. Um, there will generally be a decrease in the sperm quality from the initial when you're at home in your comfort to when you come here to a different environment. But those are not drastic where you have really great sperm and then you just don't have any sperm at all. Um, so we see that, and then when we freeze them, we thaw them, and freeze to thaw. With sperm, we're looking at in the millions. So sometimes a couple million is lost through the thaw process, but still there is sufficient amount of sperm to be used to fertilize. With the fertilization of the sperm, there are two ways in IVF, and I didn't really get into the nitty gritty of it, but there are two techniques that are used: either conventional IVF, where you take an egg, you put some sperm, and you let the sperm swim around on its own for fertilization. The second technique that can be used is ICSI, or intracytoplasmic sperm injection. That's where a single sperm is selected from the embryologist, the best sperm that we see, and then they take that single sperm and they inject it directly into the egg to help with the fertilization process. So that's a technique that can be used to when with the thaw. And then when you were talking about when you're talking about sperm washes after they are thawed, or for an IUI procedure, or for IVF, sperm washes are conducted. There are different types of sperm washes that go into the andrology portion of things, and there are different devices that can be used to assist in washing the sperm to get optimal results and the best motile sperm for helping with fertilization.
Perfect. All right. I'm going to check to see if there's any more questions from the audience, but I think we're good. Khalil, I really appreciate you taking the time tonight. It was really informative. As somebody that went through surrogacy 10 years ago, it's fascinating to see how far things have come. And we'll be sending out this recording to any participants,
Perfect.
and I believe it will also be available on the Fertility Friends website going forward. So thanks again for your time, and look forward to connecting maybe for another one of these at some point.
Perfect. Thanks so much, Kevin.
Thank you.
All right.